like to get us started and keep us on schedule today. Thank you so much for making time out of your day to join a virtual conversation where we're talking about rural needs action for the bleeding disorders community across America. We've got folks dialed in from all time zones, I think. So it's either good morning or good afternoon, but it's a Monday. No, it's not. It's a Tuesday. And we're getting this week started on the heels of appreciating our veterans and headed into a season of spending time with family and the holidays. And it's a perfect opportunity for us to come together and have some conversation while we round out this calendar year. On behalf of Hemophilia Federation of America, I want to especially welcome you. My name is Mary Catherine Moffitt. I am part of the leadership team at Hemophilia Federation of America. I'm the Vice President of Policy and Advocacy. My job here is to lead all of our work around leading and collaborating with coalition partners and especially the community on policy issues in particular that impact the community's access to affordable and safe coverage, care, and treatment. And so I share all that and connect it to the conversation we're having today because what is most important in engaging in advocacy, speaking up for our issues, and following policies that directly impact the community is that without hearing from you what the issues are and what you need in order to live a life where having a bleeding disorder doesn't impede what you need to do and achieve for yourself or your family every day, without that insight, we can't do what we're doing well. So this is the beginning of a conversation that we'll have and continue throughout next year that we're very excited about leading, especially through very generous support from a number of our sponsors who are joining us today and who we'll recognize later during the break. With that being said, I want to introduce you, if you don't already know, that the Hemophilia Federation of America is a traditionally, from its start 30 years ago, grassroots, patient-centered advocacy organization that is committed to championing the needs of families who are living with bleeding disorders like hemophilia and von Willebrand's disease, among others. Our job and our responsibility is to advocate for safe and effective therapies and quality, affordable, accessible healthcare coverage, without which living with a bleeding disorder for life as a genetically inherited disease is one that you have to have. So we see that as our call to action always, especially in the coming year. So think about what would it mean for you to live a quality of life that isn't defined by your bleeding disorder and potential barriers that you face in all of these access issues. And to the extent that you're comfortable for the next few hours that we spend together in this summit, by design is to bring together lots of different groups and points of view. And I hope that you'll consider sharing those points of view. Here's what our goal is for today. This summit, while we only see some of us, we don't get to see all of us. We are together virtually in one big meeting room. And we're together from lots of different points of view and backgrounds. And our goal is to have this inclusive conversation and achieve an enhanced understanding of what rural life and barriers to care look like for people living with bleeding disorders, and identify solutions that could advance equitable care for all. That means that if you live really far away from where you would seek treatment on a regular basis or in an emergency, you're not facing the barrier of poor outcomes in addressing a bleed or accessing treatment on a regular basis because of those barriers and others that we know exist for the impact of rural access to care. We're going to try to achieve 3 things today, and I want you to keep us honest. Here are our objectives: to engage in collective conversation about what we know exists for rural access to care with a bleeding disorder specifically. And so we've brought together a lot of different points of view to make presentations today, to lead conversation, and also answer questions. But the other really important participant in the summit today is all of you. And we want to give you the tools that you need in order to chime in and share your perspective, because only a few will be sharing their screens today, and only a few of us will you see on screen like you see right now. But everyone who we don't see are points of view that we want to ensure get shared in today's summit before we wrap. That being said, our second objective is to understand what's already being done, what kinds of good ideas are out there and being implemented in parts of the United States and communities that address the kind of barriers that exist in being able to easily access care and emergency treatment with a bleeding disorder. And third, our last objective is to explore what's not been considered and what's not being done, and who in our community across the bleeding disorder spectrum is still getting lost in the shuffle, or not being heard, or doesn't have a place to convene safely, and doesn't have someone that you identify with and can connect with in order to remove those sort of barriers to care, ultimately make life easier with a bleeding disorder in the sort of framework of all the other things that life throws at us on a regular basis, just being a person in America. So we want to explore those unmet needs. And our job as host of today's conversation on behalf of Hemophilia Federation is to be able to learn about what you have to say and what we know, and bring all that information together in one place so that we can figure out what next. So I mentioned that our overall goal is to bring together lots of points of view. So let's take a quick poll. Let's see who's here. You should see on your screen a pop-up that asks you, this is the same part of your registration, that asks you to identify which of these groups would you say you belong to. You may wear multiple hats. So you can pick, I think you have to choose one. Oh, Matt, you've got it set so that hosts and panelists can't vote, but if you're able to change that, we're happy to. Otherwise, let's see who's out there not on screen. It looks like we've got about 70 or so people who are signed in on our summit today. Okay, Matt's telling me, I'm revealing all of you what the wizard is saying from behind the curtain. Transparency is my #1 value. So Matt's telling me that we don't get to vote because we're already off mute. So we don't get to vote. If you've got results in, let's just get a snapshot of who's here. The magic. Okay, it looks like we've got a lot of representatives from community-based organizations with us. It looks like we've got patients, consumers, and caregivers at about 18% of our group. 2 times that are community-based organizations. It looks like we've got lots of folks who identify as a clinician or who are part of a health system. That's really exciting. You can see we don't have anyone who represents the payer voice, but a really important component to a lot of the work that we do. So I would very much welcome ongoing conversation and to welcome into this fold the voice of the payer. And we've got a number of folks from industry, so drug manufacturers specifically, and specialty pharmacy, I think falls into that category. Okay, terrific. Matt, thanks for sharing that with us. So that's who's here. I would challenge you to think about using this diverse audience as a place to ask questions that you wouldn't maybe have the chance to ask to those diverse groups if those aren't folks that you see on a regular basis. So here are some tools that you can do to make those questions shared. But the second thing I would like for you to consider is throughout this conversation, you saw who's missing or who, isn't fully represented in this conversation today. We would love to hear your thoughts about who would have a really important voice from personal experience or professional experience in having conversations about what are the barriers to care, especially when you live in a rural community, and how can we make sure that in our work continuing into next year, we get those really important perspectives included in the ongoing conversation. I would love to hear from you about that. So here's how we're going to use today's virtual summit to be sure that everyone gets to engage in conversation in a way that makes most sense. And I don't have to remember it. We get it written down so we have it to include in our report moving forward. So there are 3 things you can do. 1, I would love for you to think about asking questions of our panelists of the issue overall. It could be a question that you brought with you, regardless of what is presented today. It's something that's pressing that you'd really love to pose. I invite you to ask questions throughout the day. The way our summit will be organized is that we are divided into 3 sessions. And at the end of each session, we'll have time for Q&A from you, some questions that were teed up for our panelists, and we'll get to hear from all of our presenters in that session about their thoughts on your question. You can ask your question at any time throughout the day, but we'll have those 3 separate times to go through and find out what's on your mind. You should use the Q&A function that should be at the bottom of your screen in order to ask your question. So you can submit that Q&A tool to submit your question, and you may even see it pop up on the screen. I'm not really sure what the wizard has set up, but that's where you can ask questions throughout the day. The second tool is if you may be hearing our voices, but you're riding in the car, you're running carpool, you're on a route for work, or you're just not using a full screen monitor, you can use a button at the bottom that says raise hand. You'll have to wait a minute, kind of like if we were in a big room and someone needed to come pass the mic around. You'll need to wait a minute to be taken off mute. It's an automatic setting in Zoom, but you can ask your question aloud and use audio instead of typing it out. So that's the second thing you can do. And the third thing you can do throughout the day, and especially when we have prompts on the screen, is use the chat. So the chat is different than the Q&A. The Q&A is set up to ask specific questions, and at the end of today's summit, Zoom will produce a long list of the questions that were asked. The chat is like a running dialogue. If someone says something that really resonates with you, or you have, curiosity about, or you hear someone that give them a shout out, you can use the chat. And you can use the chat liberally. Feel free to share your thoughts and comments so that what we get from this is as much connection as possible. All right. Great news. I'm done. You are here. So let's do an agenda check-in. So we've just spent about 15 minutes getting ourselves oriented. And now we're going to dive into session 1. This is the part that I enjoyed the most. I would like to welcome everyone to community member and recent HFA advocate, but not a stranger at all to advocacy and leadership in the community. Adam, I'm passing the mic to you now.
Hey, Mary Catherine, thank you so much for that introduction and for going through today's meeting. And I just want to take a moment to thank everyone for joining today as well and taking time out of your days. I know everyone is busy, so we appreciate it. As Mary Catherine said, my name is Adam Alver. I'm a community advocate and patient with severe hemophilia A. I currently live in Austin, Texas. And here in Texas, I'm a member of the Central Bleeding Disorders, Texas Central Bleeding Disorders organization. Just kind of my tie to today's summit is I am originally from a small town of about 300 people in rural Minnesota. And as I'm sure many or all of you here are familiar with, I did spend a significant portion of my life very far away from quality care, including, time going to emergency rooms instead of HTCs and things like that. So that's a little bit about me. With that being said, it is my pleasure to facilitate the first session in today's summit, which is how does rural access to care impact equitable access to care? For the next 60 minutes, we'll be hearing from community leaders and people like myself living with a bleeding disorder and learning about what the barriers look like to getting our medications, seeing a bleeding disorder specialist, ideally in an HTC, treating a bleed, dealing with emergencies, and being connected to other community members when we live in communities that are further away or disconnected from those more central, maybe support systems. As Mary Catherine mentioned, I do want to encourage everyone to use the chat feature, share your comments, your thoughts, personal experiences. We're more than happy to see all of that. And we do also want to make sure that everyone uses the Q&A feature so you can ask questions and follow the speakers. And we'll open up the floor afterward to answer questions by the panel. With that being said, I want to introduce this session's speakers and panelists. First, we have Sue Martin. She is the Executive Director at the Bleeding Disorders Association of South Carolina and the Director of the Voice of 46 Project. And there is a special guest with her, South Carolina community member Tamara Sargent. We also have Melissa Compton, Executive Director of the Lone Star Bleeding Disorders Foundation, also here in Texas, which supports community members living anywhere in South Texas from El Paso all the way to Beaumont over by Louisiana. We also have Brooke Loving, the executive director of the Bleeding Disorders of the Heartland, which serves the state of Iowa and her own family, where she and three of her children currently live with von Willebrand's disease and have to deal with navigating care and receiving support from rural Illinois. And finally, we have Ashley Lacey, a community member and maternal child health nurse in Memphis, Tennessee, who has been volunteering in the community for as long as she can remember, including the Tennessee Bleeding Disorders Foundation and HFA's Board of Directors. Sue, I will turn it over to you and Tammy to get us started.
Thank you, Adam. Good afternoon, and thank you to HFA for inviting me to share our Voices of 46 Rural Outreach Program. This project was made possible by a charitable grant from Genentech and HFA's Impact Grant sponsored by Santa Fe, so thank you to all of you. I'm going to quickly go through my slides, and I was going to introduce you to our member Tamara that Adam just spoke about to provide some additional lived experience as an insight living in the rural area of having equitable health care and her struggles as a woman in achieving treatment for her hemophilia status. However, she has COVID today and is really under the weather. So I'm going to discuss at the end a few things that we discovered together and before I turn this over to Melissa. So to begin with, on our slide number one, just for reference, our chapter serves the entire state of South Carolina, and it's divided into three regions, the upstate, the midstate, and the low country. And we do this also in our member database as well, including other data such as counties, zip codes, where they reside, what HTCs they live at. On this slide, you could see where we started in June, including how many members we had in each one of those counties and where the HTCs are located within our state. Today, we have 51 people that we're halfway through the project who are living with bleeding disorders in South Carolina that have taken our survey. Next slide. Why we started the Voices of 46 46 project spun out of a 2022 Health Equity Summit we hosted in Charleston, where we had several working groups addressing barriers to treatment care. A particular interest was the outcomes from our rural working group and the conversation notes that were provided to us at that summit. To address their concerns, we thought, well, how awesome it would be to visit with them and learn from our members in all 46 counties of our state the barriers that they faced and provide them with any resources that we knew about, any solutions that we can help, but really to get a very big picture of what the rural community difficulties they have. So in June, we began our project, and we have visited with 19 counties so far. We also created a resource book to provide at every meeting and every event that we've had since then as we host events. You can see for time's sake some of the things which are included in the book. This is just a little snapshot. Some of it are where HTCs are located, their addresses, contact information, all the patient assistance programs that we know about, and our various programs of services we provide, among other resources, including our national organizations. Next slide. We had specific goals and objectives for this project, and a way to measure that was to create a survey that we asked all of our members to take once they were at our events. Everyone receives a hard copy of this book for reference and a My Voice Matters sticker and magnet. The basic goal was to get a real snapshot of the major access barriers within each county, zeroing in on zip codes with common barriers, and discover other difficulties that our members face. Next slide. This slide is a visualization of the many county voices we have captured so far and where we have been, represented by the pin marks. We're excited to say that we have voices of half of our counties in our state represented by those with bleeding disorders who have taken the survey. Next slide. On this slide, we show some of the demographics of those who have taken the survey. Of note, 70% are white, 18% are Black, African American. However, we do have many voices of many different ethnic backgrounds, including mixed races. 66% of those taking the survey are caretakers of children, followed by those who are personally affected. And of these individuals, 58% are those with hemophilia A, followed by VWD and our platelet disorder community. We're really happy to see those voices. And of course, our hemophilia B and our rares were also included among the conversations. We also did, next slide, sorry.
I got carried away.
That's okay, next slide, no problem. We also did want to provide some education while we were doing the survey. For people and to see what our community really knew about. We wanted to see where they were being treated and where they, if they were not being seen at a federally funded HTC, why, and what were some of those barriers. Our early results show that most are seen at an HTC yearly, with 21% being seen multiple times a year. Most of our members are seen in Columbia, which is in the middle of the state, but it was really good to see that our new satellite clinics that the HTCs have developed, which is just fabulous, are reaching more rural areas and people are getting there, which helps with the distance. However, we learned that 22 to 28% of the surveys participants didn't know about our HTCs. They didn't know about the network and what that was like. When we asked them why they were not seen in a federally funded HTC, the major answer was the distance was too far, it was too costly, there was too much time needed to take off of work, insurance mandates told them where they had to be seen, and they also were not referred to HTCs from another healthcare physician that they thought they should be. Next slide. On this slide, you can see the survey shows the distances members traveled for the HTCs, what challenges they faced, and where they see the need for education on bleeding disorders the most. We asked that question from them, what they thought. 30% of those surveyed traveled between 30 to 90 miles one way to their HTC. They thought that the emergency rooms, urgent care, outlying hospitals were the #1 challenge for quality care and treatment, including need for education in the dental care, and then even specialists that they're referred to. They need to have that education on bleeding disorders. Next slide. This slide shows the financial challenges our members face, and with the number one barrier, no doubt, is our copay costs, followed by missing work and then a loss of income from that. Some of the other struggles they mentioned was that they needed childcare for our single moms or single dads or single families to get to have the hospital stays or infusion care. They needed infusion care teams. Many people do not self-infuse and they have to go to the emergency room, and that's a real lacking. That is lacking in our state. Most clinics, they would love to have a little bit more clinics so that they didn't have to take off work. There's very few days that they can get in. Evening appointments would be great. These are the things that they suggested. And that in our state, in our middle or in the low country, we have MUSC, which is a non-federally funded hemophilia treatment center where many of our patients do seek care. They will age out, and they're wondering what's going to happen after they age out. So this was a great way for us to share with them that they will be seen in the mid-state in the middle. So there is care for them but they may not know. So this was a great teaching thing for us. Many stress that it would be helpful if our hematologists can talk to the other doctors and educate them on bleeding disorders. That was of great importance to them. Next slide. Gas cards also would be helpful for traveling, satellite offices, and mobile units. We did ask them about mental health. We wanted to know what they thought about their mental health, and 60% of them were satisfied, stating that they were satisfied with their mental health or their access to it, but they did have others that stressed that they didn't have the availability or the affordability to afford the services. The last thing we asked, what I don't show here, is that we wanted to know about us. We wanted to know what they thought about this outreach, what they thought about us. Were they members that come to our events? And how did they feel about that? And 97% of the survey attendees so far were coming to our events, and they were satisfied with them. And most of them found that the local outreach and this was very beneficial, and they enjoyed learning and engaging with others in their local counties. They felt that they had more in common. They were smaller groups, and that led to more conversations between them during these events that I haven't seen before. So that was really super special. So this slide just shows that we're still ongoing. And then you can see that we have our little magnet there in the survey that we put out all the time. The biggest takeaway that I see so far is that we have to ask our community members what their barriers are. We have to listen to them, and we have to ask. And we learned a lot of different things when we discovered when I met with them and where they were. Where I thought maybe that it was a short distance, being an hour, maybe that hour ride was a very rural long road, or 60 minutes or 60 miles, and it took like an hour and a half. So we have to really talk to them, ask them what their barriers are, and then take note, and then find some solutions. So that's about all I have on that. I'm just going to switch really quickly and share in regards to Tammy. We just went through, like many other places, a hurricane and a natural disaster. And what we did find out is that as much as we want to believe that we are ready for a natural disaster, when you lose your power, you lose your electricity, you lose your phone, you lose everything, your trees are down, that can be very, very isolating and very frightening for people that live in rural areas. And as Tammy suggested, when she spoke of her issue of trying to get treatment or trying to get treatment care, having trees down in front of her driveway, not being able to get out, was a true difficulty for her. And so rural areas are treated last. We take care of our cities and more populated areas first. So we need to do a little bit better being prepared. So that's just a very brief story of where we are with our Voices of 46. It's been a great, fabulous, fun thing to do, and I'm excited to get the outcomes once we get them all. So on that note, I'm going to turn it over to Melissa, who has done this, segues right into what she's been doing in our outlying communities. So thank you very much.
Great. Thank you, Sue. And thank you, HFA, for asking me to present today. Like Sue mentioned, I'm going to talk today about our outreach to our rural healthcare providers in Texas, why we need to do outreach, how we do it, and the key takeaways, what we've learned from this. In Texas, as I know in every other state, there are patients we know with bleeding disorders not receiving care because of where they live. They're too far away from the treatment center and they rely on local clinics and emergency rooms, local hematologists for their care. And we know that often these centers are not equipped to provide the comprehensive care that a patient with a bleeding disorder needs, or they may not even be diagnosed. And even in a large healthcare facility, we know that that can spell disaster for a patient. So next slide, please. So this map, as you can see, rural patients in a state the size of Texas have access to care barriers for sure. They must travel to get to a hemophilia treatment center or the distance that they must travel to get to a hemophilia treatment center for their yearly comp visit, or much less in an emergency, is just not possible. On this map, I've marked 2 of the chapters in Texas. I am down in Houston, Lone Star, and then a shout out to my counterparts in Dallas, Texas Central Bleeding Disorders. And then in the blue stars, I've marked our HTCs. So you can kind of see our HTCs obviously are in the larger cities of Texas, but we cover so much more space than that. So a couple of examples, El Paso out in West Texas, 7 hours and 53 minutes, just by mileage, not counting traffic, like Sue said, the rural roads, things like that. Almost 8 hours to get to your treatment center. From the Rio Grande Valley area down in the south, 3 hours and 50 minutes to get to the nearest treatment center in San Antonio. That's just not doable. Reliance on cars, the cost of gas. How are you going to drive 8 hours for a 9 o'clock in the morning appointment? You're going to have an overnight stay. And we know we have hundreds of diagnosed patients, and we continue to meet newly diagnosed patients in all of these areas and everywhere in between. So the red stars are a few of the areas that I'm going to talk about our program today that we've had successful outreach across the state. Not just my chapter, but also the great work that Texas Central is doing in the northern half of the state. We split the state kind of from El Paso across Austin, Houston, to Louisiana border and south, and Texas Central covers north. So that is our why. We know that we have patients in these areas that do not have access to the comprehensive care that's needed at a treatment center. Next slide. So now for the how. How do we identify where we need to do this education and outreach to local healthcare providers? We rely on our community members. We know where our patients are, and we ask them where they go for care. What primary care physician do you go to? What hematologist do you go to? When you have an emergency, what emergency room would you go to? We also created, one of the things that we really struggled with the last few years was, how do we reach all of the OB-GYNs in Texas? You send a mailing out, they're going to get an envelope and throw it on their desk, and it's going to get lost. So we created packets that any woman could take to any OB-GYN across the state, and their well woman check and say, hey, even if they don't have a bleeding disorder, we're encouraging friends of people with bleeding disorders. Will you take this packet to your doctor so that they're aware of these symptoms that one of their patients may present and may need a diagnosis of a bleeding disorder? We rely on industry, especially our specialty pharmacies, help us identify and connect with newly diagnosed patients who may not be seen at a treatment center, and healthcare providers that they know are caring for patients in these areas. We have very close relationships with our hemophilia treatment centers. Several of them do mobile clinics throughout the state once or twice a year. One of our treatment centers in Houston goes to El Paso. The one in San Antonio goes down to the Valley and does a mobile clinic so that these patients have access to the comp care at least once a year, in addition to who they're seeing in their local area. And then we're able to connect to those local doctors. The Nurses Conference, since 2017, we've been attending the Texas School Nurse Conference, and recently we've started to go to the Texas State Nurse Association that doesn't just attract school nurses, that attracts nurses from hospitals, ERs, urgent cares, local practices. And we've made so many connections there, and that's where we've gotten several of our requests to come out and do presentations at local hospitals and urgent care centers for their patients. In fact, just a couple weeks ago, I was somewhere and I had a couple nurses looking at each other saying, you remember that patient that was in a couple weeks ago? I wonder if they had a bleeding disorder. So to see that light bulb kind of come on was kind of neat. We also do some presentations at our local Chamber of Commerce meetings that they will bring in healthcare providers and do healthcare specific presentations. And they'll give us some time to present on bleeding disorders. And we've made some connections there as well. Next slide, please. So this is just kind of a picture of some of the outreach that we've done. Sometimes it's an exhibit, sometimes it's a presentation. We have information about the chapter so that if these rural facilities find a patient with a bleeding disorder, they can connect them to the chapter. We do a little bleeding disorders 101. I worked closely with our treatment center here in Houston to get, all the bleeding disorders 101 information that we needed to present, how to identify symptoms, what tests need to be run to diagnose, symptoms to watch for and undiagnosed, and then what to do if a patient who knows they have a bleeding disorder comes in, knowing that they can call the local HTC. So I provided all 6 of our Texas HTC's contact information and phone numbers for them to reach out if a patient comes in with an issue. We provide resources like the MASAC emergency room recommendations and links to toolkits, publications from both HFA and NBDF, symptom trackers for women. Our chapter worked with one of our HTCs several years ago to create an emergency care guide for patients that they carry around in their car or their go bag. And that can help an emergency care center to kind of go through what to do to treat a patient that comes in. Next slide. So our key takeaways are pretty simple. Rural HCPs need the information. They want the information. It makes a difference to rural patients. We have been connected to some patients who didn't know about HTCs. They've gone to a local hematologist, and that was all they knew. And so now they are making the effort. And we as well do some helping hands, gas cards and transportation, hotel stays to help patients get that comp care at least once a year at an HTC. But that is my part, and I am going to turn it over to my colleague, Brooke Loving from Iowa.
Thank you, Melissa, and thank you, HFA, for asking me to share today. Next slide. So this is my family. We have 6 kids, and then we have bonus kids that are significant others to our big kids. The distance for us, we live in Aledo, Illinois, and so we are smack dab in the middle of 2 HTCs, one in Iowa and one in Illinois. Our family you can go to the next slide, sorry. Our family consists of 4 of us having von Willebrand disease, and each of us has a different treatment plan. Our episodes of bleeding vary greatly. Kane and I, we're pretty easy peasy. If we have surgery or we have wisdom teeth or something like that, we have to do treatment, but otherwise we do pretty well. Kason is our active boy, and he's always getting hurt or just doing normal boy things, and so he does require a lot more treatment. I put some pictures of him out because he's very active and he loves doing all the normal things that kids should be able to do, and our family has chosen to not allow his bleeding disorder to define him, and so we try to make the most practical way to be able to give him treatment so that way he can be able to still engage in those activities. And then something that just the top pictures of him with our advocacy day. He has become a great advocate for the bleeding disorders community and really enjoys being in that atmosphere. So I'm looking forward to seeing him kind of evolve. And the last one is of my daughter, Katie. Katie was diagnosed when she was 9 with von Willebrand's disease, and she's been infusing since on her own. And she actually does all of Kason's infusions. He's working on doing his himself. He just lacks a little bit of probably the courage, maybe a little bit, and then just that his veins are not very good. So we're hoping that he kind of grows a little better and can do that on his own. But right now, Katie kind of is the master of all of that. So big families in general seem to bring a bit of chaos. So as you can imagine, we live a pretty busy and chaotic life. Managing our care has been pretty easy overall. But we do have a pretty awesome HTC and staff that has helped us get there. And then also being involved with our local chapter was a tremendous help, offering prior to me being involved with a spot that I am now, but as a community member, a lot of our support came through our local chapter. And so I strive to provide those kind of services to our members now. However, times that we have needed help do occur when an injury happens at home. And in those times, we have had difficulties getting the care that we need because we live so far away from an HTC. And so those times have proven to be difficult. We can't always get to the HTC when we need a little extra help or when we're not getting the stick. We don't have nurses that live super close. And so we rely heavily on people that we know and can get to, or we have to go to a hospital that's about 40 minutes from our house. We do have, only because they have factor on hand, we do have closer hospitals. However, they won't administer our product for us. And so our option is to go to the hospital that's 40 minutes away or to one of the HTCs. And unfortunately, our hospital that does have factor on hand, we have not had good experiences with. We've actually had several bad experiences there where my daughter was in a car accident and the HTC had called ahead of time and given plan of action and everything. And when we got there, we actually waited for an hour and a half and they still had not given factor. And she had incurred like a seatbelt bruise across her chest and things. And so the doctor had come in and he had said, you know, I don't visually see anything, but he never had examined her. He had never pulled her gown down, nothing. He just said, you're not visibly, I can't see any blood. You're okay. We're gonna come back to you. We have somebody else who needs things. And so I was like, well, just give her the factor and then we can go from there later. And so I think like as a affected member, one of the biggest needs that my family especially has experienced is that we have great care from our HTC. The lacking part is that we don't have the great care from our rural ERs, and not because they're not wonderful places, but simply because they're not educated. And sometimes even if they are educated, because you have advocates in there. I remember the last time that I was in there with my son, I actually took out my card for work and was like, but I know what I'm talking about. I'm not just some crazy mom. Like I am crazy, but I'm not crazy about this. I'm educated on this fashion. And so having them willing to take direction. That was my timer, that my time is up. So I'm going to talk really fast. And so they have to be, the doctors not only have to be educated, but they have to be willing to take direction from those when they're calling their HTCs to them. And then another, both professional and personal level is that the time and expense of trips from the HTC. So sometimes the day-long appointments just aren't possible for families to take off all day to be gone. And with the drive, you know, that adds 3 hours, like for my family, that's on top of the time that you're there. And especially if you have like 3 kids being seen. So it's just not simply something that a lot of families can do. And so we as a chapter do try to offer gas cards, and to assist with this challenge in the future, we hope to be able to collaborate with our HTC to be able to get into clinic visits and provide snacks to families, to be able to support them for the long time slots that they're there, and to be able to share that what services our local chapter can offer to the families. And now I will pass it over to Miss Ashley to be able to speak about her experiences and viewpoints. Sorry, I went over, Miss Mary Catherine.
Hi, everyone. I'm Ashley Lacey, as mentioned. Thank you to HFA for having me as a speaker today. I am from Memphis, Tennessee, and I have type 1 von Willebrand disease. I was diagnosed at the age of 6 years old. And although I do not live in a rural area, I do live in an area without an HTC. So it's very difficult going to a hematologist that does not focus on specifically bleeding disorders. I'm currently being treated at the West Cancer Center in Memphis. And fortunately, I only have to go for treatment when I have a procedure done or I'm getting surgery, so I don't regularly infuse. Most patients that are there are being treated for cancer, and so everyone usually assumes that the other people are as well. I've had patients ask me questions around cancer treatment, and they may be a new patient that's being treated and they want to get my perspective. So I kind of just let them know I'm not here for that. I'm being treated for a bleeding disorder. But it's also so difficult to see so many people being treated for cancer, and it just makes me feel grateful that I'm in the room for a bleeding disorder and not being treated for cancer. Actually, I went a long time not being under hematologist care, and it was really the people in my local community who were really encouraging me. Like they were on me, like, you need to be treated. And as mentioned, I'm a nurse, so I know better. I know that I should have been under hematologist care, but I knew that there was not a HCC in my area. So I'm like, okay, where am I gonna go? So when I did seek out a hematologist, I was able to find them. So when I went to my first visit, I asked them about resources. Do you know of anything for people with bleeding disorders? What resources do you all offer? Is there anything that I could get support around? And of course, the answer was no. The hematologist was not aware of any resources, any support. But I was, because I was involved with my local chapter. So I eventually did share the information with him, but I just kind of wanted to see what with someone going in who didn't have the knowledge, what kind of information they would be given. And unfortunately, there was no information shared because they just didn't know. But that encounter made me realize the importance of HTCs, because a traditional hematologist that does not focus on bleeding disorders would not necessarily know the resources. So I was like, we need HCCs, because imagine a new family. They don't know about their local chapters. They don't know how to get involved. They don't know about the resources. So it's very important that hematologists, just not HCCs, have information about the resources that are available. So I work to educate myself to fill the gaps on the things that I will normally be getting from an HCC. And I do that by connecting with my local community, staying abreast to the new research, the new medications that are available for von Willebrand disease. And just I also go to talks around hemophilia, because even though I don't have hemophilia, they're so closely related. I learn a lot when I go to the talks and the meetings that are related to hemophilia. Ultimately, as patients, we know our bodies best. So it's important that not only we take the correct information to the provider, whether it's a HCC or not, but we have the information going in so that we can collaborate with them and make informed decisions around the best care that we can get. Staying connected with the pharmaceutical companies is also a good way to just know like the updates on the information. Going to things like this, going to your local chapter events, all those are good ways to just stay informed and to use the resources. Use the resources provided by your local chapter, by the national chapters, and just learn as much as you can. And also collaborate with other physicians, your primary care doctor, also your gynecologist. I was going to a primary care doctor, and for some reason they didn't have it in my chart that I have on Willebrand disease. And I'm like, I know I've told y'all this. So just making sure that, your other providers are aware of your disorder as well, so that they can all collaborate and make the best treatment plan as possible for you. I believe access is the most important thing to close this gap. Right now, people in my city do drive 3 hours away to go to an HCC. I opted not to do that at the moment. There may be something that I do in the future, but I think another way that we could potentially close that gap is having mobile units. That was brought up earlier. So I think, even we may think this situation is isolated to just rural areas, but I'm an example that you can live in a big city with a lot of medical resources and still not be having the treatment that you need as far as being an HCC. So, this area that we're dealing with, don't for the people who live in rural areas, don't think it's an isolated event, and that other people who live in bigger cities may not get it, because it's something that we're all facing. But I think, like I said, mobile units and just trying to, there may not be a long-term solution, but it may be, a shorter solution. It may not be super sustainable, but maybe it's something that could bridge the gap until we are able to get more brick and mortar buildings, and more trained hematologists who focus on bleeding disorders, because like I said, it's very important that our providers know the resources that are available, because people do need this help. And I just want to thank you all for taking the time to listen to my story. Again, thank HFA, and I'll pass it back over to you, Adam.
All right. Thank you so much, Ashley and Brooke and Melissa. We really appreciate all of your feedback and input on these topics. So, obviously we want to make sure that everyone gets the opportunity to hear about what it's like to live with a bleeding disorder, and we really appreciate all the outreach that you guys do to make care more equitable for everyone. I do want to ask a question to everyone on the panel here, and if you want, just go in the same order that we gave the presentations on. If you could make one change to the healthcare system to improve access for rural residents, what would it be and why?
I would make the mobile units. I would make the satellite offices that we have so that people can get there easier and quicker. I know that the treatment centers work really hard. I do go to clinics, so I understand that they work hard to get people in and out, but they need more funding. Treatment centers need more funding so they can have more doctors and get more patients in and get them in and get them out quicker, and then have the local, make them more local for them. I think that would be great, giving them that access. Access to the care is everything.
Perfect. We greatly appreciate that, Sue. Melissa, what are your thoughts? And if you need me to repeat the question, just let me know.
Well, so I was going to say, in a perfect ideal world, more HTCs. But I'm going to go with, yes, Sue is probably a little more realistic. Mobile clinics, local access. Yeah. But perfect world, money's not an issue, staffing's not an issue, more HTCs.
Okay, perfect. Thank you so much. And then Brooke?
Yeah, so I also agree with the access of being able to get it different places in the state. But I actually just learned about some like satellite locations that I didn't know about. So I think before that even happened, like I think you need to do those, but I think like the biggest piece after that then would be that you have to make sure that it's branded out there, that people know that it exists. Because you can have those all over the place, but if the people don't know they exist, then it doesn't serve its purpose either. So I think it's kind of a twofold, is not only having them, but then also making sure that not only the medical professionals, but also the patients know that they exist. Because if we don't know that they're there, we also, it's not going to fix the problem either. So that would be mine.
Yeah, that's
I,
definitely very important. And I apologize, Ashley. You go right
I'm
ahead.
sorry. I apologize. I agree with everything these ladies said, but I will also add just professional development and continuing education for other providers who may or may not be hematologists, because most people have some sort of provider in their area. So making sure that those providers know about hemophilia, von Willebrand disease, our other disorders, just educating them. So even if we can't get to an HCC, we can get to a provider that has some level of knowledge about what we're dealing with.
Absolutely. Yeah, I completely agree with that as well, Ashley. Ray, I do want to ask you, I know we've had quite a few comments that have popped up in the chat during the time that we've been talking, and I know that there have been a few questions that have been asked. What questions do we have, Ray, for the panelists?
Thanks, Adam. We've got one that came in while Sue was speaking, and I know we got some wonderful responses from our friends in Texas. But Sue, the question was, how did you identify bleeding disorder population folks not served by an HTC?
So we ask that question when they become members of our organization, or when they are referred to us by the hemophilia treatment centers. We have a very great relationship with them and a referral system. We refer them, they refer their patients over to us to join. So it's in our database. So I literally asked them where they're seen. There's no, it doesn't matter where they're seen. It's just something that we ask so that we have it. And then again, on the surveys that we've had, just sending that out to everybody and asking them, are you seeing it at a federally funded treatment center? And we gave them where they are. We gave them those, as Brooke was saying, we gave them the satellite offices. Some of them, when they made comments, they said, "Oh, I didn't know there was a satellite office," which these are very new. They're just in March, so it's taken some time to get people to understand that they're out there. So really, again, it's just asking and taking that time to ask people, gathering that data, and then finding out if they're not going there, why. And to the point of what everybody's been talking about, it's the distance, it's the time off of work, and if people are taking a whole day off of work, they're not getting paid. They're having to take a vacation. So how can we make that easier? What kind of resources can we give to them? And if money was no option, as Melissa said, it'd be great to say, here's $250, get you to the treatment centers, take a night, whatever, but they can send people out to take after school and off of work. So that's a loaded question, but just getting that data by literally by asking and then keeping the data. We know where they're treated, when they register, and then when we, kind of follow up as time goes by. Thank you for the question.
Yeah, thank you. And then Adam, just briefly, a few other sort of distance-related questions that were specific to the Texas presentation, and Melissa has already, in her proactive manner, gone ahead and answered those questions. So thank you, Melissa. But if folks haven't seen those questions in the Q&A, please go and click on that link so you can see the conversations going on there. And that'll be it, Adam, for now.
Okay, perfect. I hope you guys don't mind. I had a question as well that I thought might be good to bring up, and maybe specifically for you, Sue. I know we'll be covering this a little bit later as well, but could you or any of you share on what differences you see in rural care across socioeconomic backgrounds and specific diagnoses? So, von Willebrand's versus hemophilia, for example.
I could just share from what the folks have said in our rural areas is, their hospitals and their doctors, they're clueless. They just don't know. They don't know how to treat the patients, and then they have to go to the more larger hospitals for their treatment. I asked one of our members, and I said, "So let me ask you this: if your son was in an accident right now, what would happen?" And they said, "Well, we would go to the local place really fast to, bandage him up, and then we would head on out to the bigger facilities because they can't treat us, and we already know that they say that already." So again, more education to the local hospitals and the local doctors is greatly needed. I just don't know how we can get all that done. But that was some of the comments that they had made.
I really appreciate that, Sue. And that kind of actually leads into the next question that I have for everyone. And again, I'll pass this along to each of you. Looking to the future, what are some actions that you believe healthcare organizations or government agencies could take to make healthcare more accessible and equitable for rural communities? And again, if you'd like to just go in the same order you presented in, that would be great.
I must be brain dead. What was the question again? I
All
apologize.
right, no worries, Sue. So looking to the future, and again, kind of segueing off the last couple questions, what are some actions that you think healthcare organizations or government agencies could take to make healthcare more accessible and equitable for?
Well, I think that they need to fund it more. We need more funding, and they need to recognize that, especially rare diseases and chronic conditions need to have healthcare and healthcare access, and we need to get more funding from our government agencies to shore up our HTCs. Like Melissa said, we need more of them. We need more doctors there, and I think it's just a matter of understanding the care that we need and taking the time to listen and see and to put some importance on it, especially those that live in rural areas. Just because you don't have someone that walks in every single day in your hospital doesn't mean that you shouldn't have their medication, doesn't mean that you shouldn't have their knowledge of how to treat them. And we just need to have some more importance in that area. And I would love to see them look at that and look to us to help educate them and to the patient's lived experiences. Oops.
Great, thank you so much. I'll turn it over to Melissa.
I would agree. And I would say, I mean, it kind of tags along what Sue said of even though you don't have someone walking in every day, I mean, we always kind of say, oh, most doctors have the one line in their biology book or in their med school book, one paragraph about bleeding disorders. And especially with von Willebrand's, how many people, are going undiagnosed. It's not as rare as everyone used to think. And I think just that education and getting it out there that your patient might have a bleeding disorder and just have that where it's an automatic trigger that, they think about that where they're not doing that now.
I agree with that, Melissa. And I think that the first step, like where can we start on a smaller scale, right, is that they give funding for us us advocates, right? Doesn't have to be a chapter, but advocates to go in and get those trainings done, or to offer the hospitals and the physicians and the doctors like do regional trainings about it, or maybe, or something like once a year you kind of have like a continuing ed class that is all about diagnosing a bleeding disorder or referring people to be diagnosed for a bleeding disorder, but just giving them the kind of snapshot of these are the things to look for would be helpful, because I think physicians don't want patients to come in and tell them what to do. And as a affected person, we all know that we are very knowledgeable in our diagnosis. And so if you had a higher up doing the knowledge giving, it would go over a lot smoother than a patient coming in and saying, you should be sending this person. Like, I think there's more oomph behind the people that are above us, probably, to be able to get that through.
I agree. Oh,
ahead.
did you want to say something, Adam? Okay.
Nope, just was passing it to you.
Okay. I agree with everything already said, funding and education. I just think about how we sometimes encounter providers who I always like to look in their face when I say I have von Willebrand disease, and that kind of tells me everything I need to know. So just that lack of knowledge, sometimes the knowledge gap. Somebody said patient empathy. I absolutely agree. Just having empathy for what we're dealing with, whether or not you understand the ins and outs of the mechanics of our disorder, and then just taking the initiative to actually learning about it. If you don't know, humble yourself as a provider and learn about it. So I would say funding plus education.
Absolutely. I completely agree with all those points, and I appreciate you guys offering your input as well. Ray, I want to pass it back to you briefly. I do see that we have a few more comments and some questions both in the chat and in the Q&A as well.
Yeah, thanks, Adam. Question about internet access in these areas and the availability or if HTCs offer virtual visits. Anybody speak to that?
So I think our HTC does do virtual visits. So for my son who doesn't have bleeds often, that was an option for us because we're not needing such in-depth clinic visit. But for two of my kids who don't bleed more on the mild side, going through a virtual call wouldn't be probably the best option, because you're going to need your blood tested. And like, that's for me anyway, like their levels need to be tested, and living in the rural area, we don't have all the testing that needs to be done for that at our local hospital. So like the von Willebrand especially, right? It's fickle, so it changes. So you can't just be like transporting it and stuff. So like it has to be done at the HTC. but I think that virtual is definitely, for those of us who maybe don't require the in-person, is definitely an option that people should, or if it comes between I'm going to be seen or not be seen at all, a virtual is better than nothing. But you do miss a lot of the gaps. I mean, you're not going to see a physical therapist, you're not going to be able to see the dentist, which those are all key points of going to an HTC for your comprehensive clinic.
I have one more that came up in the chat. If you had to make the case for clinicians to learn more about bleeding disorders, what would be your value proposition? So why learn about treating bleeding disorders?
I could just speak to that really quickly.
Yeah.
There are hundreds and hundreds and hundreds of thousands of people with bleeding disorders that are undiagnosed. Our women's clinic that our HTCs are doing right now, I apologize for this glare, that they're doing right now, bringing all of our carrier women that have bleeding disorders, they can, they'll have a lot more patients, which can provide more funding into the HTCs and into the hospitals. But I think that's one reason, but because we need the care too. They've got a huge amount of people. They go into healthcare to serve and to help people who need their help and their education and their services. And I think that's a calling for them to learn, so they know how to identify that first, and then not give the wrong care and give someone a hysterectomy because they're bleeding and they really just needed treatment for their von Willebrand's disease or something else. And I think that's tragic that that's still happening today. That's just kind of my 2 cents on that. I think that they would benefit a lot from that.
Was the question why doctors should want to learn more? Was that the question? Okay, so my tidbits on that is that a doctor, I mean, their whole purpose of existing is to help their patients to have the best care that they can possibly have. And if they're wanting to do that goal, then learning all that they possibly can, if it's offered, would be the thing that they should want to do. And if that's not what they're wanting to do, then they're probably not in the right profession to give the best care possible. And I'm not saying they have to, because they have busy lives and they have their own personal lives. But I think that, like I said, like once a year, having a little refresher course, everybody can give up one day out of the year to learn more about one certain entity. And like, obviously underdiagnosis is a huge issue. And like Sue just mentioned, all the things that can go wrong by not being educated. And so I think like just as human beings, if we want the best for those next to us without being a doctor, without being a nurse, wanting to educate yourself on the things that are going on around you. And right now, right around us are people who are affected with bleeding disorders that are not receiving the care that they should and are not being diagnosed because people just don't know. And so I think that would be my answer for that.
Yeah, I mean, my answer in the chat was because a bleeding disorder emergency can be the difference between life or death. And every person should have care to make their life better, to improve their health. So
I just read Morgan's response, and I love that. It's just delayed treatment can have lifelong repercussions for a patient with a bleeding disorder. And I have personal with my son, that is exactly, and it's because I wasn't educated. And so I guess that's probably why I'm passionate about wanting to educate people, is because my choices affect my son and his future. So I think that was a good thing in the chat from Morgan.
I really appreciate all your feedback here as well on that question. And I know since we just have a little bit of time, I kind of wanted to ask another follow-up question to all of you. It seems like kind of a common theme here within the chat and with the responses that you guys are giving is a lack of education or materials that those local or satellite clinics or maybe the more isolated areas have. So my question to you is, how could member organizations or state chapters, things like that, provide more frequent and quality education to some of those areas and physicians so that that specific issue can be less frequent than maybe the other ones like travel and finances and things like that?
So just going in order, like Melissa said, reaching out to the outlying hospitals. We also go to nurses' clinics, make sure that we're at their regional meetings and stuff and have a booth and just, spread that education as much as we can. As organizations, if we can reach all of those emergency regional, everybody has to have, a conference, a higher up or whatever. If we can get into some of those, I know that like school boards, school nurses associations, try to get into their speaker bureau and do some education would be great. I know that's hard because we're a disorder that most physicians don't see. So a lot of times they want to get something that they'll get some value out of because they're going to see a patient. And I think that that's a heartbreak for me that we just need to get out and get some more education, whatever we can do to bring that to them and provide that to them since they don't have the time to look it up themselves.
Yeah, I would say the conferences are a great way. You hit a 4-hour booth time and you meet all the people at the conference and they really are hungry for information. I mean, our table's wiped out with information, and especially school nurses, because those middle school nurses are some of the ones that find those girls first, right? And why are you coming in here every hour? There's a problem. And to get that information in their hands is so important. So I think the school nurse conferences and just the Texas nurse conference as well has been huge for us to make those contacts and get the information out. And I had another thought and it just left my head. The speaker bureaus. You mentioned the speaker bureaus. Now that we've been going for a few years and we have that relationship, the school nurse association, they're redoing their website, and I was like, oh, could we because they've got a little pull down menu and you can learn different things about different, ADHD and all the common things that the schools learn about. And I was like, how do we get a tab on that? They're like, well, let's talk once we start, rebuilding our website in the spring. And I said, well, do you have a newsletter? Can we put something in your newsletter or your e-blast that you send out to all the nurses? So all those are great connections to make and don't take a lot of time. I mean, it's a 1-day thing usually to go set up. And we've had board members come with us. We've had, all kinds of people go to these conferences.
Great. Thank you guys both so much. Brooke, did you have any comments?
Nope.
All right. All right. Perfect. Well, I guess
I had
Ray. Oh, go ahead. Go ahead,
Oh, I'm
Ash.
sorry. I had a quick comment. I was just gonna say, perhaps figure out a way to offer this continuing education credits, because I know a lot of nurses, doctors have to have those. So if we could figure out a way to incorporate that type of education and training into something that they need to do anyway, I think that'll be a good footing.
Absolutely, completely agree, and I appreciate that additional comment, Ashley. I know we're almost wrapping up here. We've got about 5 more minutes. Ray, are there any other items or anyone present here? Are there any last questions that we have before we finish up this specific session?
Yep, I've got one that came into the chat, and it's HFA specific. The question is regarding whether HFA or anyone else has CME available for providers that patients could promote, similar to how the Lone Star chapter is handing info to doctors and practitioners. And what I will say to that is I will check with our education director and the folks who work within our Learning Central on our website to find out what's available, and we'll make sure that that's part of the follow-up that comes out with the evaluation by the end of this week.
Thank you, Ray. There's some good chat that's just coming in that's a response to that question, it looks like. And also, that question may or may not be a plant. But after this break, that is what, well, that's not true. After the next two breaks in the third session, we actually have a presentation teed up about some of this continuing education that's targeted especially toward women and girls who are underdiagnosed, as Sue mentioned. So it was a perfect question. It tees up some of the content that we plan to present, but also we can continue to provide resources and education in the follow-up. Adam, thank you. To the panel, thank you. This has been such a rich conversation, and this session was setting the stage for what are you experiencing, what's happening, what are you learning in the communities, and what you've shared still gives us just a peek into some corners of the country. But your work has been so thorough. So I am so grateful to you to spending your time preparing for today, to being part of this somewhat alternative presentation of bringing us all together in a room. In that spirit, we are going to take a break. I know everyone will heart and share, but thank you, thank you. Please know in the silence, we really appreciate all of the time and thoughts that you shared, and to everyone in the chat. Keep it up. Everyone's an A+ student right now. This conversation has just been really, really interesting. We are scheduled to come back at 20 minutes after the hour. So I will have a couple of slides up while we all step away and take a break that give you some resources that haven't been mentioned already. Feel free to grab those, and we'll try and drop those links into the chat as well. And we'll see you at 20 after. Thanks, everyone.